Okay, good morning, everyone. We're going to have an update on neurocritical care today. I'm not going to go over the usual statistics that I've been doing the past couple of months. And it's my pleasure to reintroduce our neurocritical care division faculty. The program is rapidly growing. It's been through a convulsive change this past year. And although most of the people who are participating today know all of the panelists, I want to just take a moment to thank the five of you again, as well as to reintroduce you to the rest of the team. So Neha Dengayich is assistant professor of neurosurgery and neurology. She's co-director of the neurosciences ICU and director and co-founder of the NEMAT program. You can see her training, bringing her all the way through to Cornell and Columbia, and finally settling with us at Mount Sinai. She's definitely become a leader. I don't know if she anticipated she was going to have such a role, but she has risen to the leadership position and has embraced it, and is obviously really someone who we follow and admire. So it's going to be wonderful to see how you continue to grow here. Cappy Lay, just like me, got his undergrad from Cornell, then went on to Columbia and NYU. He started out here about 5 years ago, has an interest in emergency medicine because of his residency, and has taken a leadership role as well as co-director of the neuroscience ICU, with very strong ties to the rest of the institution, particularly the ED and Institute for Critical Care Medicine. Alex Reynolds, another of the Princeton grads, also through Columbia, and finally to us, has also taken a leadership role. She's very interested in research in the metabolic effects of liver failure, and has pursued continued research and funding opportunities in that area, as well as starting her own family and continuing to grow in her leadership positions. John Lang is a stroke neurologist as well as neurointensivist. He has also been thrown into the crucible in a leadership role at Mount Sinai West, and is increasingly active in all of our department activities. It's really wonderful to see him integrating so nicely into the program. His interest in vascular neurology fits very well with the focus on ICH over at Mount Sinai West, but he has many other interests as well. And Caitlin Riley, another Princeton University grad, also through Columbia, and did her fellowship with us, is interested in many aspects of critical care, particularly neuromonitoring, and as well as educational roles, increasingly taking on those roles with us. So it's a pleasure to have the five of you. I'll turn it over to you, and interested to hear your update on how we're doing with neurocritical care after COVID.
All right, thank you, Dr. Pedersen. This is Cappy Lay. I wanted to can you hear me okay?
We do. Okay,
great. So, we're going to break up the presentation. The five of us are going to speak sort of separately, one after the other. I wanted to start by just, first of all, laying out, we want to just hope in this presentation can give you a sense of what neurocritical care's involvement has been in the COVID mission here at Mount Sinai Hospital over the last 2.5 months. So, yeah, you can go to the next slide. Alex is going to be running the slides for us. So, I think first off, we have to go back to last year. As you said, it's been pretty much a whirlwind over the last 1.5 years. Several years ago, I think the hospital and Dr. Pedersen had the vision for, an expanded role for neurocritical care at Mount Sinai. And that was really brought together by the planning of a brand new neuro ICU. That ICU took years of planning and, lots of stakeholders involved. You can go to the next slide. And just looking at what that unit looked like, we had 18 brand new individual beds, a CT suite on the unit. Nursing had expanded dramatically with 25 new hires. All the nurses were ENLS certified. Next slide. And we have this beautiful space, that was really built for a growing team. You can go to the next slide, Alex. Just to give you a picture of what this space looked like. We have fellows and trainees coming through, a fantastic group of nurses. This is what our unit looked like. And in October, we opened, ready to take on new neurosurgical patients. We started bringing patients in October. Next slide. But at the same time this was going on, obviously there was something else happening in the other part of the world. So on December 31st, as we all know, the first case of COVID was sort of announced in China. And by January 23rd, Wuhan had been placed under quarantine. We go through this list that everyone's familiar with now. By January 30th, there were 9,000 cases identified. And then on the February 29th, we had the first U.S. death in Washington. The next day, on March 1st, we had the first case identified in New York State. And by the 7th, we had declared a state of emergency in New York. The first 2 deaths came in New York State on the 14th. And by the next day, the confirmed number of cases in the U.S. had surpassed 3,000. And so I think at this point, we had been prepared for really a storm that was coming. And we knew it was going to hit, but we weren't sure what it was going to look like. A quote from Dr. Rupa Kohli-Seth, the director of critical care services here at Mount Sinai, was that we're waiting for a tsunami and hoping it will be a wave. So on the 16th of March, the KCC9 team, our neurocritical care team, was notified that we should move all of the neurocritical care patients in order to make capacity for what the hospital thought was going to be a surge of COVID patients. So the next day, I was on service that day when we moved everyone over, and for about 24 hours, we had no patients on KCC9. And I think there was a feeling that, we might not be, that maybe it wouldn't be so bad. But within 2 days, we had 10 COVID patients. And by the 26th, we were not only full, but so full that we had moved to a protocol of actually putting 2 critically ill patients in each room. And that's really, the wave, came very quickly. So, for those of you who aren't familiar with taking care of respiratory failure patients, the typical patient in the ICU had presented with bilateral pneumonia and severe hypoxemia, and we saw it over and over again. Really the MO of these patients was that they presented with incredibly poor lung compliance. Maintaining oxygenation in these patients was definitely a challenge. We tended to employ, pretty standard therapies for ARDS, which include low tidal volume ventilation. A vast majority of the intubated patients were paralyzed with very high dose sedatives. And for a team that's used to a neurologic exam, these patients, we almost had no neurologic exam for sometimes days on end. Most of them were on vasopressors. There was a very high incidence of shock, in part related to the iatrogenic administration of high-dose sedatives, but also patients with secondary bacterial infections requiring pressors. We saw a very high incidence of renal failure, and a large number of patients ended up on renal replacement therapy during their stay with us. So the best data we have, that we've been able to pull in a short amount of time was that, in the about 6 weeks between March 18th and April 30th, on KCC9 alone, so for those of you who aren't at Mount Sinai, we had, I believe, 7 ICUs dedicated to COVID care during this period, our unit being one of those. And over those 6 weeks, we took care of 98 COVID patients and had just under 30 deaths. Next slide. So, one of the first, when we first rolled out, obviously one of the major concerns was that providers were concerned about becoming infected themselves. There was an extremely high level of anxiety related to going into the patient rooms. While there was a concern that we might run out of PPE early on, I have to hand it to the hospital that we never actually ran out of PPE. There was only a period of time when we were recycling masks for a little bit, and they were re-sterilizing masks, but I think there was an outpouring of support from people really all over the world to make sure that PPE was provided for the team. So here you have a couple of our providers kind of fully gowned up. And then if you look off, the picture on the right shows what we were able to do with these isolated beds. So the medication pumps were moved outside into the hallway, and that allowed us to, infuse medications without the nurse, kind of minimizing the nurse and physician exposure to the patient. And so there was, sometimes about 15, 20 feet of tubing from the door to the patient. Next slide. I think the most inspiring part of this experience, certainly for me, and I think a lot of my colleagues would echo this, was the incredible outpouring of support from all departments in the hospital, and what really represented a tremendous coming together of people from different specialties to really provide care for these patients. To give you a sense of the kind of effort that was put forth, we had contributions obviously from ICU nursing, which really formed the backbone of this project. ICU, there was about 50 different nurses who took care of these patients. Some of them were travelers and from other departments, as well as our own core neurocritical care nurses. We had advanced practice providers, both PAs and NPs, from neurosurgery, emergency medicine, anesthesiology, cardiothoracic, and breast surgery. We had residents from pediatrics, neurosurgery, fellows from cardiology and critical care. Besides the 4 Mount Sinai intensivists, there were also 10 other critical care attendings who spent time in our unit, leading these groups of providers. The hospital came up with a proning team, which was really, amazing to watch. When we had a patient who needed to be prone, put in a prone position to improve their oxygenation, we would call this team and they would come down to the ICU room, suit up, go into the room, and help us turn these patients. I mean, it was really, I have to say that the proning team was quite impressive. Respiratory therapy obviously provided a tremendous benefit to these patients in terms of helping with ventilator management, intubations. We had patients self-extubating at times, where you have to go into the room emergently to reintubate the patients, with oftentimes very little time to sort of get prepared and go back into the room. Here are a couple photos of our general work. The way we would keep track of data was to, convert our brand new doors with, we started using a dry eraser on every door to keep track of the data, ventilator settings, ABG results, drip doses, and that's how we kind of went from one room to the next to keep track of what was going on with all these patients. And on the right, you have just a picture of proning a patient. Next slide. And then, the last thing I want to just leave you with before I move on to the next speaker is that family support was an incredibly important part of this experience. So physicians and APPs from different services provided daily phone updates to families. given the visitation restrictions that we had. The palliative care team at Mount Sinai was instrumental. I mean, they had an embedded palliative care team in our unit to help, have goals of care conversations. Many of these patients, were extremely ill, and we had to have those conversations early with families to talk about, whether there was any benefit in continuing aggressive medical care. And then finally, iPads were used to allow these virtual visits. This has been documented at other institutions as well. But I think while it was certainly not optimal, it did, I think, allow families to have some closure with patients when there was no further treatment. So at this point, I'm going to pass it off to the next speaker, Alex, I guess another one more slide. So, there was a lot of experimental therapies. I'm sure all of you have heard in the news that there were, all sorts of different things being tried. And I think these is, at least 10 different therapies that were used, for patients with different criteria. I have to say at times it felt a little bit disorganized in terms of the various treatments we were using. Many of which now, I think as data becomes more available, we're realizing may not have been as effective as we hoped. Next slide. I guess at this point, I'll pass it on to Dr. Liang, who's going to talk a little bit about the response at Mount Sinai West.
Great, thank you. Okay. All right, so I guess, I think Cappy basically touched on similar issues that we all face now. I think I'll point out a few subtle differences. Mount Sinai West is a relatively smaller hospital. We have 514 beds as opposed to over 1,000 beds at MSH. And unlike MSH, where you see Cappy's slide of all the attendings and residents and fellows that you had to pull from, the neurosurgery and neurocritical care service at MSW West is really mostly NP and PA driven. So there's no neurocritical care fellows. There's really limited support to pull from. But because of the size of West and we have different staffing structures, so we did decide to tackle things slightly different. Actually go back to the curve. So this is the hospital-wide data, not just for the unit, but for Mount Sinai West as a whole. And you can see that at our peak, we basically had about 63% of our census was admitted due to COVID. And with multiple rapid responses every day, our challenge was actually finding enough ICU beds and making sure how we can staff those beds. Thankfully, we're right now down to only 35 COVID patients in the hospital as of this past weekend. To paint the picture a little clearer, Mount Sinai Hospital has 7 ICUs that were dedicated to COVID, whereas at West, the neuro ICU is one of 2 ICUs in the entire hospital. So that does make every bed that we have vital. So here is our annual numbers. You can see we were on a trajectory of increasing volume year over year. We took a hit in a sense. Our census dropped in April with the COVID, but even with the drop, it's still on par with 2019, and basically all these patients were COVID. And as Cappy mentioned, all these people were in the hospital, in the unit for weeks on end with sedatives and paralytics and everything else. So, we really had to be flexible and adaptable to take on this extra volume. And obviously it's not something that the neurosurgical ICU typically would see. So one of the things that we had to do was really capacity creation. We started creating ICUs out of every area that we can. We convert step-down areas into ICU. We convert the floor into a step-down. We turn the entire PACU into a very into an open negative pressure room, one big room, and it converted into ICU. And what we did was we created 4 teams, and as we created new ICUs, we identified new team members that can lead these teams. So it really became the MICU and SICU, the neuro ICU and anesthesia. We all took one of these units and provided care around the clock. One of the lessons that I learned personally, if there is a second wave or something of that sort, is, how to manage your supply, right? Your ICU supply. We at Mount Sinai, we have this relationship with the National Jewish Health Respiratory Institute. And so we actually had intensivists from Colorado who came over and stayed with us to supplement us. And, I think that is a very different model where at MSH, you have 40, probably 40 plus critical care attendings. At West, we have 7. So with just 7 attendings combined between neuro ICU and MICU, there was no way you could cover all these ICUs without additional help. And rather than the typical pyramid model where you would be pulling people from pediatrics and dermatology and internal medicine and putting them all into the ICU and have the intensivists oversee all of them, and you would put a large strain on your ICU staff. So I think being able to pull intensivists from lesser hit areas was definitely a good idea. Because you just bring all that specialties while stringing your teams. One of the things is we had, because we were a smaller footprint, we had, closer communication with every single team that was in the hospital, and everybody wanted to participate and everyone wanted to, divide and conquer. So we had anesthesia came and they took over all intubations, and that, even if you're fully capable and confident and you say, you want to intubate this patient, anesthesia basically stepped in and said, there's unnecessary risk to put everyone in danger. So whenever you had an intubation, anesthesia comes in full PPE as a 2-person team. And, when they arrive, everyone gets out of the room. The nurse steps out, everyone steps out except for the 2 anesthesia that come fully gowned. And this increases your first success rate and also limits the potential exposure to the rest of your team. Similarly, we also had the general surgeons, they stepped up and they became our procedure team. And, with the same rationale, as you can imagine, all these patients, they end up with multiple lines, from arterial lines to central lines, dialysis catheters, chest tubes were quite common, unfortunately. So having them do all the procedures while we're rounding, it definitely does help a lot. And as as at MSH, where a proning team did not exist, neither did it exist at Mount Sinai West. One of the things, I pulled a few shifts at MSH, and then I saw, several things I really liked when I was there, so I brought it back to us. And one of the things was the proning team. So actually, Janesh Patel, one of our other neurointensivists, he actually led the proning team effort along with the physical therapist. So as you can see, it takes a large force, right? You have multiple people, and on the top right, you have Ernest Badalamy, one of our neurosurgical chiefs. He's managing the airway and basically leading the proning team. Whoever's at the head watching the ET tube is the leader of the proning team, and they're the one that dictates when to flip and when to turn. So, and obviously, you see in the next slide that the proning team, it really wasn't a skill set that anybody was just walking around with. So we actually had to use a simulation center and educate all of our team members, all the physical therapy team, and how to safely prone a patient. And I will say, this is Shane. For those of you who come by Mount Sinai West, he is vital. He is our housekeeper, and honestly, without him, nothing moves in the unit. And he always comes and does anything you ask him to. And he is, I just think he deserves a shout out. I'm just gonna finish this off with a very recent survey that came out from the Society of Critical Care Medicine. And you can see it's basically had 9,000 somewhat respondents, most of them concentrated in the COVID hit areas. And it basically asked people, what critical care needs can they identify? What were their concerns? And as you can imagine, second to PPE masks is ICU staffing. That is always everyone's main concern. And, I felt the way that we dealt with it, it worked. Now, another question that they asked people was, about stress, about what you did to protect your family. And you can see that, all these things are something that we kind of probably did at one point or another, either changing clothes, showering before going home, or, living in a hotel room, or, just isolating yourself from your family. These are all really real issues that everyone in the ICU faces. And if you can see, we're asked to rate your stress, where 10 is the most stressful you've ever been. Pre-pandemic, most critical care people would say, their personal stress level was about a 3. But with COVID, everyone's obviously stress level jumped up to the max. And, Neha will probably talk about stress a little bit, so I don't want to steal her thunder. So we'll move on to, some other silver linings of this COVID pandemic. One of the things that came out of this was telemedicine, right? Similar to how we're doing these telegram rounds, telemedicine acceptance just skyrocketed. And, I think it gave us a momentum. It allowed us to purchase all these in-touch robots, telemedicine robots, that is now in every ICU. And it definitely helps us to consult and manage cases, in hospitals that don't have neurocritical care, or that we can't easily bring every single patient to a neurocritical care unit. So in the center photo, this is a photo right from this past weekend. It was me and Devaldo Camara, one of our neurosurgeons. We were consulting on a TBI case at Mount Sinai Morningside. And, it definitely, having telemedicine, it improves the care, and it also allows us, once again, to identify who to transfer and who can treat in place, so that you don't overload your ICU capacity. And of course, you must take time to, to breathe and to celebrate. And there are things that, we, through this whole pandemic, we were able to celebrate. We had new hires, we had birthday parties, we had Jamie on the right, one of our nurse practitioners, and a surprise bridal shower through the pandemic. I think that's important to help de-stress. And I'll leave with this last photo of this press release that we found. So Mount Sinai West was the first hospital in New York to admit a coronavirus patients. We had the first coronavirus patient in New York City, and this gentleman, Mr. Saval, he was critically ill, intubated, everything, for almost 2 months, and he was our 500th discharge. And you can see he's putting his butterfly on the wall right before he left the hospital. So every time we have someone leave the hospital, we have them put one of these stickers on the wall just to remind us of how far we have come. And I think that does give people hope when they come to work. All right. And I think with that, I will stop and move on to Kate.
I don't know if Cappy's gotten disconnected, so I can talk about this part.
Can you hear me?
Oh, now I can, yeah.
Sorry, I think I was muted, unfortunately. So yeah, we're gonna skip ahead just for a second. So one of the observations, made by many of the intensivists as we started to accumulate experience with COVID was that there seemed to be this prothrombotic state that was showing up both in terms of macro thrombotic events, patients showing up with STEMIs in large strokes, ischemic strokes, and pulmonary embolisms. That there was this concern that these patients might, for one reason or the other, be hypercoagulable. As we started to look at laboratory parameters, we saw a profile of increased inflammation in a prothrombotic state that seemed to come up over and over again. So a lot of these patients had very high fibrinogen levels. Their CRP, IL-6, which is a marker of inflammation that we started looking at, as well as D-dimers were very elevated. And in contrast to DIC, which we sometimes see in patients with severe infection, these patients tended not to be coagulopathic in the sense their INR was normal and their platelet count was normal. So after some, initially, there was some, I guess you would say, different providers, were sort of on kind of individually deciding how to deal with this. And the critical care medicine division group at the hospital formed a working group to design an anticoagulation protocol for these patients. And so that was formally rolled out in late April, even though anticoagulation had started to be given before that. And really it hinged on patients whose D-dimer was elevated above 1.5, for those patients who had worsening oxygen requirements, or any patient who had needed upgrade to an ICU. The thought was that microthrombi, both in the lungs as well as potentially in the kidneys and other organs, was contributing to this epidemic of multi-organ failure that we were seeing. However, unfortunately, with any treatment that where we don't know the efficacy of, there's always a risk for either that treatment won't work, or worse, that it may cause untoward complications. And so I thought it was worth, bringing up a few of the cases that we had observed. This was one I just want to present was a 77-year-old woman with hypertension, diabetes, who had been admitted to the hospital with 5 days of shortness of breath. She was a hypertensive patient, but she was neurologically intact. And the team started a heparin drip on the basis of her laboratory parameters and her oxygen requirement. But then on hospital day 3, while she was speaking on the phone with a family member, she was noted to be acutely unresponsive. and was brought to the CAT scanner, where it demonstrated this very large, right frontal parietal ICH with the sort of appearance of a coagulopathic hemorrhage. Neurosurgery was consulted and took the patient, emergently to the OR for a hemicraniectomy. However, by the end of the case, the patient's exam had already progressed to brain death. In a very short amount of time, we saw several other fatal intracerebral hemorrhages that were associated with full-dose anticoagulation. And it's unclear whether, some of these patients may have had ischemic strokes that then bled. As I said before, neurologic exams on a lot of the intubated patients was near impossible. So by the time, something was noted, often it was because a pupil had become unreactive. And so we did have some complications associated with full-dose heparinization. Now, I think it's still an open question whether the benefits may outweigh the risks of neurologic complications from anticoagulation. But it's certainly something that I think as we continue to anticoagulate patients that we need to look very carefully at. So if Dr. Reynolds, maybe you want to take on, go ahead.
I believe Kate is on. She's just trying to unmute herself.
I see.
Hello?
Okay, that's working. Yep, you're on
Okay,
mute.
great. So hi, I'm Kate Riley. I'm going to be talking a little bit about some of the neurologic manifestations that we saw in our unit and how it kind of relates to the spectrum of neurologic disease that has been seen in other people treating COVID-19 around the world. So one of the most interesting, I think, neurologic symptoms that a lot of patients, even patients with relatively minor disease, have noted is anosmia and inability to taste. Other patients with COVID-19 have also noted to have potentially an increased incidence of strokes and seizures. And some of the more interesting syndromes that we've seen both in our unit and through case reports in other institutions are Guillain-Barré Syndrome, necrotizing encephalitis, and transverse myelitis. So I'm going to talk about 3 cases that we had in our neuro ICU that kind of highlight the interesting spectrum of disease that we see in these as a neurologic manifestation in COVID-19 patients. So the first case is a 67-year-old woman who had a history of breast cancer. 10 days before admission, she developed a non-productive cough and nausea and anorexia. But 5 days prior to admission, she developed some low back pain, and that was radiating down both legs. And then 2 days prior to presentation, she developed worrying weakness in both lower extremities and then some tingling numbness in the lower extremities as well. She came into our ER, where she was noted to have a normal mental status and at the time, normal cranial nerves. She had weakness in her lower extremities on the initial exam that was worse proximally greater than distally. And she also had some proximal weakness in her upper extremities. Her tone was decreased throughout and she was areflexic. An LP was performed at that time that showed no white cells, but did show an elevated protein to 210, showing like the classic albumino cytologic dissociation that is kind of a hallmark of Guillain-Barré syndrome. Of note, her SARS-CoV-2 PCR was negative in the CSF at that time. She was diagnosed with Guillain-Barré syndrome at that time, and of note, she also was hyponatremic to 115 with labs consistent with SIADH. Over the course of the next 4 days, she actually had a fairly rapid progression of symptoms. Her legs became completely paralyzed. She developed new weakness in her hands. And she had a new left lower motor neuron facial droop, and also some bulbar weakness that manifested primarily as some hypophonia. She also developed new dysautonomia, which was initially just a bit of tachycardia, but over the course of the 4 days, kind of rapidly turned into rapid swings in blood pressure. And that's how she met us, the intensivists, when she was moved to the neuro ICU. We treated her with plasmapheresis for 5 sessions, and unfortunately, after her second session, she Due to her bulbar weakness, aspirated, became acutely hypoxemic, and had a cardiac arrest. She was intubated and had a rapid return to spontaneous circulation. She later failed extubation again due to bulbar weakness, but when she completed all 5 sessions of plasmapheresis, she did well, was able to be decannulated, and was ultimately discharged to acute rehab with full function of both of her upper extremities. Some of the kind of notable features of this case for people who are not familiar with taking care of Guillain-Barré Syndrome patients is that she has some findings are a little unusual. She has a patchy distribution of weakness that's worse proximally than distally. Usually, classically, you see more of an ascending paralysis, although this is not outside the realm of what has been reported. She had early radiculitis. She had some cranial neuritis and a relatively rapid progression of her symptoms. Her course was also notable for dysautonomia, which tends to be the worst complication of Guillain-Barré syndrome. And both the symptoms and the onset of her symptoms relative to the onset of the symptoms of her viral symptoms and the negative SARS-CoV-2 PCR in her CSF seem to suggest that this is a post-infectious inflammatory etiology rather than direct viral involvement. So far around the world, there have been 6 total reports, either of case reports or small case series of Guillain-Barré patients in the literature so far from China and Italy predominantly. And what they document is a pretty broad spectrum of Guillain-Barré syndrome. Like there is both demyelinating and axonal variants that have been reported. Some patients have ascending paralysis, like I mentioned. Some patients have Miller-Fisher syndrome, which is Guillain-Barré syndrome that starts as a predominantly cranial nerve abnormalities that progress downwards. And some patients have actually been described, like our patient, as having a patchy distribution. And both radiculitis and cranial neuritis have been noted in some of the other patients as well. So I highlight this just to say that there's no clear COVID-19 phenotype for Guillain-Barré syndrome. It seems to have a very broad spectrum, kind of similar to the broad spectrum of pulmonary manifestations we've seen from COVID-19. So our second case is kind of a medical mystery. So she was a 59-year-old woman who initially presented with 4 days of cough, myalgia, and shortness of breath. She called an ambulance, and her O2 saturation was noted to be 40% in the field, which is very abnormal. She was brought to the Mount Sinai Queens ED, where she was intubated. Prior to intubation and was able to speak to that doctor, she was noted to be awake, speaking but breathless, asking to be taken care of, complaining of shortness of breath, and was noted to be moving all 4 extremities. She was transferred over to us in the KCC9 COVID ICU, where she was almost immediately sedated and paralyzed and treated for ARDS, severe acute respiratory distress syndrome, a severe manifestation of COVID pneumonia, for the next 2 weeks. When we weaned her sedation after 2 weeks, when she was starting to breathe a bit better, she had an episode of upward gaze deviation that resolved with Ativan, which prompted us to get an EEG, which showed some left temporal LPDs, which was abnormal and thus prompted us to get an MRI. And the MRI showed some really abnormal findings. She had evidence, this is her DWI on 3 separate slices, and you can see that there's evidence of cytotoxic edema in the white matter fairly diffusely on both sides, and also that there's significant gray matter involvement, including to the bilateral caudate heads, which is not necessarily typical of any disease that we think of. In order to work it up further, we did an LP, which was fairly normal. Her SARS-CoV-2 PCR was negative. Thinking that this could perhaps be a post-infectious encephalitis, we treated her with plasmapheresis for 5 sessions. But unfortunately, she didn't make either clinical or radiographic improvements. So it's hard to put this particular case into a category. It doesn't have the classic imaging of ADEM, acute disseminated encephalomyelitis, or delayed post-hypoxic leukoencephalopathy, which is a rare, predominantly white matter disease that can occur several weeks after someone's had a very profound episode of hypoxia. In her case, she had both gray and white matter involvement, which would be unusual for that condition. And she had no evidence of active CNS inflammation and no virus that was found in the CNS, in the CSF. But one of the things I found that made her whole diagnostic workup to be a little bit more challenging was the delay in diagnosis due to her requirements of being sedated and paralyzed. As Cappy mentioned, almost every patient who came in with ARDS, due to their vent requirements, required very deep sedation and often paralysis. And that made getting regular neurological exams really challenging. And I think as a result, probably led to us diagnosing less neurologic disease than we otherwise could have. I just want to highlight that there has been one report in the literature of more direct encephalitis, which is there was one patient in Detroit, a 58-year-old flight attendant, who became unresponsive after a short prodrome of cough and fever. Her imaging findings were notable for symmetric multifocal lesions with bilateral thalamic involvement that was hemorrhagic, which is the classic manifestation of acute necrotizing hemorrhagic encephalitis commonly seen with influenza. But again, those radiographic findings are not what we saw with our patient. And then the third interesting case I wanted to highlight was a 48-year-old man who initially presented with cough, fever, and shortness of breath. He had progressive hypoxia for the next 3 days and was intubated for COVID-19 associated ARDS. And prior to intubation, I actually intubated him, so I know this, he had a normal neurologic exam. Over the course of the next 3 weeks, he was kept deeply sedated. On a couple of occasions, he required neuromuscular blockade as well. And after the sedation was weaned, he was found to be paraplegic, which prompted us to get an MRI of the spine, which showed multifocal T2 lesions. This is two of the representative lesions, one that's on the right, as you can see in the right lateral aspect of T5, and then a C1 lesion as well, seen on the sagittal. We did an LP as well, which showed that there was some evidence of inflammation. The white count is 10, which is abnormally high, and the protein is 131, which is also abnormally high. His SARS-CoV-2 was also sent in the PCR. I should note that this test hasn't been confirmed with the FDA yet, but we're performing it on an experimental basis. And it was also negative, so didn't show active signs of active virus in the CSF at that time. He was treated with a 5-day course of steroids and had marked improvement in his lower extremity strength. And as of about 4 days ago, he was able to stand with physical therapy, so regained a lot of function in his legs. In his case, I think it was a little bit clearer that the etiology was post-infectious inflammation, mostly because he responded so well to steroids. But again, it's challenging to rule out direct viral involvement in his case because of the delay in diagnosis, because he was sedated and paralyzed. So I think we've learned a lot of lessons over the course of the last, 2.5 months now. There seems to be a broad range of neurologic manifestations that encompass disease processes that we typically think of as being post-infectious inflammatory conditions that we see with other viral syndromes as well, including GBS and hemorrhagic encephalopathy and transverse myelitis. But because of the delay in diagnosis in these particular patients, we haven't been able to really, I think we missed our window to really identify what could potentially be direct viral involvement. And just to note, the ACE2 receptor, which is the binding receptor for the SARS-CoV-2 virus, does seem to be present on the cell membranes of both brain and spinal neurons. So there is a potential for direct viral involvement, although we have not captured it yet. And I think part of that reason is because of the challenges we've had with doing regular neurological evaluations on these patients. Which brings a potential for need for better neuromonitoring. And I'll hand it over to Alex to talk more about that.
Hey, can you hear me?
Yes, we can hear you.
Okay, thanks, Chris. So thank you for the segue, Kate. I think in the midst of all of us working extremely hard clinically to try to take care of these patients, we did find some interesting research opportunities. So, as Cappy and Kate already alluded to, the major clinical problem as neurointensivists was that we couldn't monitor these patients who were sedated and paralyzed. They were often extremely unstable on dialysis and ventilators and inhaled medications. And so they were not easy to move for imaging. And we were really trying to limit the people going into the room. And so we very much limited conventional EEG on these patients because that requires a tech to be up by the head of the bed for almost an hour. And so, there really was almost no monitoring of these patients until we lifted sedation and kind of crossed our fingers and hoped that patients woke up. One option that I'm sure the vascular neurosurgeons are very familiar with is the transcranial Doppler. So that's a really useful bedside tool, which we usually use in subarachnoid hemorrhage to look for vasospasm, but there are a lot of other abnormalities that we can detect on this sort of imaging. The problem is that similar to EEG, if you're doing transcranial Dopplers, this requires that there is the person who's performing it is by the head of the bed and manually looking for the signal. We had worked with Neural Analytics, which is a company that makes our Lucid system, which is our transcranial Doppler system. And they had this really neat robot that basically, takes the probes, optimizes the probe placement, finds the window, and then is able to acquire and maintain the signal over time. The idea of an automated Doppler system was particularly attractive in the COVID population because this really allows you to minimize the amount of time that you are in the room and at the head of the bed near the patient. And so, I won't do this system any justice, but using machine learning, this algorithm responds to the data that it's receiving and then searches for the optimal signal. And it responds to this data just like a human tech does, and much better than I do at the bedside. And so we thought that this was a really interesting opportunity to use this machine in order to monitor patients. And so thanks to a great partnership with Neural Analytics, we were able to have a robot sent to us on loan. And even more importantly, we had 2 people sent to us on loan. On the left is Kat DeSantis, and on the right is Joshua Renz. And they actually both volunteered to come to the epicenter of COVID in New York City and help us with using this machine on COVID patients. So you can see on the right, John Liang and I worked with them to identify appropriate patients who were sedated, paralyzed, or not waking up after sedation was held as a pilot project to see if there were any abnormalities that we could detect. And this is a project that's ongoing. I'll just show you a couple of things that we've noted so far. So, these are normal transcranial Dopplers. So you can see there's a triphasic wave. These are waveforms that were obtained in a study looking actually to identify large vessel occlusion. And so you can see, there's a lot of nuance, obviously, but you can see that the waveforms become blunted, that the velocities drop on one side when there's a large vessel occlusion. And the normal triphasic morphology goes away somewhat because of the blunting. These are examples of some of the patients that we have scanned with COVID-19. On the left, you can see 2 sets of waveforms that are somewhat normal. They have the triphasic morphology at least. We'll say that the velocities on the top are a little elevated. But on the right, what you can see is some very abnormal waveforms. They suggest high resistance, and the waveform morphology goes away. It's a little hard to tell exactly what these waveforms mean. I think we need a little bit more data. These are just 5 examples of patients that we scanned. Again, their exams were all kind of non-focal, just severe encephalopathy for the ones who were off sedation, or patients with no exam except a pupillary exam because they were paralyzed. I think the trend that we've seen are these highly resistive waveforms, and that could be for a couple of different reasons, which we still have to kind of work out. So these patients often have changes in their CO2 if they're not being able to be ventilated, and that can result in cerebral edema. We don't know if these patients have undiagnosed intracranial processes because these patients are unstable to move for traditional imaging. There may be a distal vasculopathy in some of these patients. We do know that there's evidence of vasculopathy in other organ systems in this disease process. And then last, we don't know whether these patients have appropriate autoregulation or not. But we have also noted several patients with asymmetries in their waveforms, even though there's no clear asymmetry in the exam that we're able to obtain. So I think there's kind of a lot that we can look into here. Another nice study that you can do on transcranial Dopplers is looking for high intensity transient signals. So this is the so-called HIT study that is very common to do on the stroke side. But basically what you're doing is you're insunating the blood vessels and looking for spontaneous emboli. So in the patients that we scanned, we looked for these high intensity transient signals. We do know there's a higher risk of stroke in these patients. And at first, we weren't sure whether these patients may have embolic phenomenon. There is cardiac involvement, and these patients do develop some arrhythmias. And so, we wondered whether we were going to be seeing any of these abnormal signals suggesting spontaneous emboli. We did this in patients who were both on and off anticoagulation. We specifically looked for patients who had a reason to be off anticoagulation, such as, recurrent GI bleeding. And we knew that in several of these patients, they were prone to clotting. Every time they had a line placed, it was immediately clotted. But surprisingly, we scanned 23 patients with no evidence of any spontaneous emboli. So I think, even this negative information is kind of helpful for us to be able to understand the pathophysiology of the clotting that's going on in these patients. I think one of the most interesting options for this robot is that it's a continuous monitor. So unlike a transcranial Doppler that's done by a tech or by one of the providers at the bedside, this robot can stay on the person's head for as long as you want it to be. This is an example in a case that we collaborated with the company on before COVID hit. This was a patient who had cerebral edema. And Dr. Riley was at the bedside and pushed hypertonic saline. And you can actually watch over the course of 20 minutes what happens as you push the hypertonic saline. The velocities are on the top, and the pulsatility index, which is an indirect measure of the intracranial pressure, is at the bottom. And so what you can see is that at the beginning, the pulsatility index is quite high, suggesting cerebral edema. As the hypertonic saline is pushed, you can see a drop. That's the orange signal. Both on the left and the right, you see a drop. And with the drop, you see a delay in the drop of the velocity in the brain. And that's actually suggesting that there's a drop in the arterial pressure, which we often see with a push in hypertonic saline. And so as the blood pressure drops, you then actually see a rebound increase in the pulsatility index due to autoregulation and vasodilation. And then that slowly improves over time. And so this continuous monitor is actually, at the bedside, where we routinely will push this with either an ICP monitor in place, or if the patient does not have an ICP monitor, then we're just monitoring the pupils. If you have a continuous TCD, you're actually able to monitor in real time what's going on in the brain. This was another study that we collaborated on them with. This was a patient who unfortunately was progressing to brain death despite maximal medical treatment. And so over time, you can see the analysis of the waveforms. On the left in cluster 1 and 2, you start to see changes in the waveforms with increasing resistance. And then the waveform below that actually shows negative flow is actually showing you the what ends up becoming pendular flow during brain death, where you have no net forward flow. And so you have both forward flow during systole and then reverse flow during both systole and diastole. And so using this sort of machine learning to understand what's going on in the waveforms can be really helpful in trying to understand what's going on intracranially, particularly in these patients that we can't monitor any other way. So we've been really lucky to be able to work with Robert Hamilton and the entire team at Neural Analytics to come up with some projects. We're actually working on some grants as well. And to our knowledge, we're the only institution in the world right now that has access to this team and is using continuous TCDs to be monitoring patients with COVID-19. And so some of the projects we're looking into are feasibility of monitoring patients who are on anticoagulation. As Cappy mentioned, we're often just hearing about these patients once they've blown a pupil. And presumably if you could detect these patients earlier and stop and reverse anticoagulation, we may not have as many deaths from ICH. We want to look into mechanisms of stroke in COVID-19. And then we're hoping to work with our Moberg team to evaluate cerebral autoregulation using both blood pressure, continuous blood pressure monitoring and continuous TCD monitoring to be able to understand whether the autoregulation in the brain is actually normal or abnormal, and whether we can try to target certain physiological variables in order to normalize autoregulation in these patients. Because we know that even if they do wake up, a lot of them are waking up with encephalopathy, and we don't really know what that's from. And so it may be that the abnormal autoregulation is actually causing neuronal injury during the acute phase. And we have an exciting collaboration with our pulmonary team as well. We have a paper that's being reviewed right now, and hopefully we'll be able to show you some more data sometime soon. And so with that, I'm going to stop sharing my screen and hand it over to Neha.
Okay, can you see my PowerPoint?
Yep, looks good.
Okay, great. Thank you so much, Alex, for a nice segue into some of the things that I'm going to talk about. I just have a few relevant disclosures. I'm the site PI for the Thrive Post-ICU Recovery Clinic, also a founding member for the Cairo Post-ICU Recovery Network, and I do have a grant for social media in medicine. Just going back to March 13th, 2020, it seems like it was a lifetime ago. And the number one question that was going through my mind at that time was, what is going to take us through this crisis? And it was very important to go back to my core values, thinking about how am I going to stay positive through all of this, lifelong learning, being really kind, both to myself and to everybody else around, and leveraging that collaborative spirit and our resilience. So scrolling through my Twitter timeline, and I find this recurrent theme where I'm looking for all the positives, and believe it or not, there was plenty of positives that came out of this crisis. The New Yorker cover from about 2 months ago really highlights what our lives on the front lines became. It was this amalgam of leveraging technology for providing compassionate care, but also being compassionate to ourselves as we're socially distancing and remaining connected to our families. The challenge in front of us was, how do we adapt our existing excellent programs that we had already put into place for our non-COVID-19 patients, and how do we continue to contribute to that mission and then adapt to the COVID-19 mission. So right from the NEMAT program, the Neuroemergencies Management Transfers program, the Critical Care Resilience program, and I'll talk about one of the projects in that program, talking about wellness, leveraging existing research collaborations, establishing new ones, and then a little bit about outreach and a way forward. So for those of you who are not familiar with NEMAT, NEMAT is one of our very important quality improvement programs within the Department of Neurosurgery, and our mission is to advance clinical care research and education for neuroemergencies in a large urban health system. Neuroemergencies, classic neuroemergencies like stroke, traumatic brain injury, etc. So this program was already established in 2017. As for the structure of the program in the pre-COVID era, we're a multi-hub, multi-spoke model. We're a disease-specific center of excellence type model. So we have disease and site-specific team members. We've got triage levels from life rescues right down to patients who might not need transfers as emergently. We have a flow chart, checklist, protocols, and a massive database that we collect data through. So what did COVID-19 do to NEMAT? So we looked at our, so in the light blue, you're seeing January through March 14th. And in dark blue, you see March 15th to April 30th. And we looked at the last 3 years, 2018, 2019, and 2020. What is striking is the number of patients that were transferred during this time period remained relatively stable. So if anything, increased from 2018 to 2019. So a little over 300 patients. But when we look at disease specific data, in 2020, the numbers seem to be driven to slightly higher than 2018, particularly in the pre-COVID January to March 14 data. And then looking at March 15th to April 30th, we do see that the number of strokes was very comparable to the number of strokes that we were seeing. If anything, maybe a little bit of an uptick as well. However, there was other disease processes, for example, seizures or status epilepticus, that we didn't see as much. In terms of process improvement and really looking at getting the right patient to the right place at the right time in the fastest possible time, we did notice that our life rescue transfer times did increase by about 10 to 15 minutes. So in the pre-COVID 2019 time periods, our median transfer times for life rescue transfers was about 85 minutes. The structure of the program had to be changed when all the neurointensivists got pulled to cover COVID neuro ICU. Our chief residents from neurosurgery started manning that 24/7 hotline. We changed to create capacity, like John and Cappy alluded. We were not transferring all patients as per our pre-COVID COVID-19 protocols, but only bringing in life rescues. So what was the true impact of COVID-19 on NEMAT? All I can say, just looking at this preliminary analysis, that having a high fidelity triage system, having multidisciplinary collaboration, no matter what the crisis, you're going to take your patients through whether they're COVID-19 positive or not. Another program that we had established about 3 years ago is the Critical Care Resilience Program. The mission of this program was to truly bring multidisciplinary team members, physical therapy, OT, occupational therapy, social work, spiritual care, in critical care teams, nursing, everybody together to truly humanize the ICU. So some of the projects that we've been collaborating on through this program was Critical Care Recovery Clinic and ICU Diaries Project, peer-to-peer support group. After about 2.5 years of planning, we had seen our first patient in our post-ICU recovery clinic. Like I mentioned, we're a Society of Critical Care Medicine Thrive post-ICU recovery network site. Here on the left-hand side, you see Miguel Martillo. Miguel and I are co-directors for this clinic. And we had seen our first patient just on Feb 11th, right before COVID-19 really hit us. So the purpose of this clinic is to increase awareness about post-intensive care syndrome, and to make patients aware that we're not abandoning them after we take care of them in the ICU, but we're going to be there with them throughout this ICU survivorship, and to really link them up to different resources that are going to help them embark on this perfect trajectory towards recovery and to cope with what are some unintended consequences in the physical domain, cognitive domain, psychological domain that come by being part of an ICU. So this multidisciplinary team, even during the clinic, the in-person clinic included intensivists, pharmacists, social work, spiritual care, physiatrists, and a research team. So why is this even important? Even in the pre-COVID-19 era, we know that the number of ICU survivors, and I'm just talking about United States data, we know millions of patients are surviving their ICU stays, and they're suffering from these unintended consequences. We anticipate that ICU survivors after COVID-19 are going to have a higher incidence of post-intensive care syndrome. And why is that? There are several factors which are directly disease related. There are several factors that are related directly to how we had to manage these patients, whether they needed to be sedated, paralyzed for longer than some of our other pre-COVID-19 ARDS patients or severe sepsis or septic shock patients. We couldn't allow family visitation. Having, Dr. Kellner says, having the family at the bedside is more therapeutic than any other therapy that we administer. Not having that in itself is probably going to lead to a higher incidence of PICS in this patient population. So we had to quickly pivot from having an in-person clinic to having a telehealth paradigm. And luckily we had planned for a telehealth paradigm, but we just ramped it up. And we got so much help from our Department of Neurosurgery, APPs, Leslie and her team, our RNs, in addition to our ICCM team, and tremendous support from our ICCM director, Dr. Rupa Kohli said. So we changed how we were going to start seeing our patients. We also changed our clinic workflow. On the right-hand side, you see a snapshot from my phone of one of our clinic patients. The workflow for this clinic, specifically creating an epic screening log. So our APPs and RNs were actively screening every COVID-19 patient who was getting discharged from the ICU. We thought of enrolling patients who had at least stayed in an ICU for 7 days or longer. They are receiving a post-discharge call to make them aware of PICS. 7 days, there's another follow-up to see how they're doing, both with the patients and their families. A lot of these patients are also going to long-term acute care hospitals or rehabs, and we're reaching out to them and then doing a 30-day visit. Just some preliminary analysis. We've seen so far 29 patients. Yesterday, we saw 6 more COVID-19 survivors. And we've had a 100% show rate for telehealth visits. And historically, when you look at this literature for post-ICU recovery clinics, one of the biggest issues in maintaining this kind of clinic is a 40% or so no-show rate. Preliminary outcomes, 32% of them reported some amount of PTSD, 52% had insomnia, about a third had depression. And when we look at their resilience or their ability to bounce back from any crisis, more than half of them had low resilience as compared to the average American adult. So that brings me to wellness for everyone who was on the front lines and everyone who was contributing behind the scenes to help the people who were on the front lines. There was a very high level of anxiety. So we brainstormed with Dr. Medicine about what could we roll out for the entire department, both our administrative and clinical staff. And on a personal note, I do believe that meditation makes a difference. It gives you a moment to reflect on everything that's happened and to unpack things, particularly when there's chaos around. So we decided to roll out a Zoom-based meditation program, and with support from our clinical research coordinators, Ian and Nikki, and Dr. Bedison's executive assistant, Ritonia, we were able to roll this out in 2 weeks. And now we've expanded the program, not just to the Department of Neurosurgery, but to ICCM, as well as our critical care nurses. So we have 2 practitioners who are volunteering, who are both very experienced. We're very thankful for that. And the program structure is essentially to capture both the day shift and the night shift, 2 sessions, 5 days a week. And we send out weekly questionnaires to see how people are doing and what do they feel about meditation as a potential strategy to cope with stress. Some preliminary data from our weekly surveys. So about 50% of our survey responders are directly taking care of COVID-19 patients. And almost everyone is reporting some level of anxiety, feeling nervous, or being on the edge. And whether meditation is helping or not, time will tell. but we're going to continue to collect data. A couple of slides on existing research collaborations and establishing new research collaborations. Alex and John's work on TCD and their collaboration with neuroanalytics is extremely exciting. And in addition to that, they're also leading the site PIs for our Neuro-COVID international collaboration, which is multiple countries, essentially trying to describe what Kate was alluding to. We don't completely understand the spectrum of neurological complications in COVID-19, and the only way to do that is to study this systematically, pooling our resources across the world. Another research collaboration that we just established, this is from our Department of Anesthesiology and the Institute of Critical Care Medicine. We are looking at several areas of research, and the Population Health Department has compiled a tremendous amount of data from our data warehouse. So we're hoping to publish some good papers from that collaboration. The Mount Sinai stroke researchers, this was a group that was already, so Joanna Fifi had already put together this group, several of us who are interested in stroke research, and with the stroke division, with our endovascular team, this collaboration is thriving, and we have several COVID-19 papers, and I'll show you a couple of them. And our social media critical care researchers practitioners group has also been publishing on COVID-19 and how social media has helped disseminate some of these correct information about COVID-19 management. Just a flavor for some of the accepted publications. So right from case series, so this was with our Department of Pulmonology, to this paper in the NEJM on the left-hand side, which got a lot of press. It was led by Thomas Oxley, describing 5 cases with elbow as a presenting feature in patients who did not have severe symptoms from COVID-19. Then talking about our departmental response on how neurosurgeons contributed to the frontline, how our residents really took on this special role and provided us with tremendous support, both in taking care of our COVID-19 patients and non-COVID-19 patients. My husband is Harpreet Grewal. He's a lung transplant pulmonologist, ECMO specialist intensivist, and we're able to extend our collaboration academically as well. And we just got this paper accepted describing the outcomes in patients, in African Americans and Hispanic patients, in about 400 or so patients from Newark, New Jersey. We have 2 other papers that have also been accepted in stroke, looking at decompressive hemicranie, and then another large cohort study of elbow patients led by Sharam. A paper I do want to highlight from the Emerging Leaders Program, the American Academy of Neurology's Emerging Leaders Program. I'm graduating from that program, and the graduation was supposed to be in Toronto, but it's all via Zoom right now. So our charge was to inform the AN on how to become a truly inclusive society. And this group of fantastic individuals that I have the pleasure of working with came up with the idea of truly thinking about the importance of inclusion during a pandemic. So this should be available soon. In terms of outreach, why is it important for the frontline provider to truly stay engaged and connected to the general public as well as our healthcare community at large, and using different avenues, right from social media to traditional media, as well as engaging with different national societies? I think it's very important that we dispel misinformation, and no matter how busy it gets clinically, I think this is a very important aspect of our mission. I do want to wrap up by saying that it's everything that we do, the source of inspiration are our patients and families. And we were able to get through this crisis and come so far and look to a way forward because of our pre-existing tremendous teamwork and tremendous collaboration. So I just want to show you some pictures which were pre-COVID-19. And the biggest difference that I see is just masks and PPEs. Everything else remained same or only got amplified. So with that, I'd like to stop and hand it over to Chris, so we can leave some time for questions. Thank you.
Amazing set of all-star talks. That is really, really interesting to hear from each of you, and really, really inspiring.
I'm going to stop sharing my screen.
Yeah. Neha, can you share some of your observations from the post-ICU COVID clinic? Is there anything you're seeing in this patient population that appears to be unique, separate from standard ICU follow-up?
So some of the things, Chris, that we were anticipating, we're beginning to see already. These patients are describing very vivid hallucinations. They're describing difficulties in their rooms are not feeling like the ICU rooms that we're so used to, having families at the bedside. A lot of patients describe feeling very alone. Loneliness in the ICU, even in the pre-COVID era, was already well described. And now I think COVID-19 has just really magnified that sense of loneliness. So that was one thing that a lot of patients described. PTSD, more than half of these patients are beginning to describe some symptoms that particularly within the first few weeks of discharge. We've only seen them in the first few weeks of discharge. I don't know how this is going to pan out longitudinally. We're also asking them questions about social stigma. Because there's social distancing, yes, it's a very important component of preventing community spread or breaking that chain of transmission. But at the same time, some patients describe that even their own families are afraid to come near them, despite being weeks out from COVID-19. So I do want to share that patients do not shed this virus 7 days or so after they become asymptomatic. So I think it's important, yes, you maintain social distancing, hand hygiene, but there is no reason to stigmatize this disease process. So, and with more than 3 million people affected by COVID-19 across the world, I think it's our responsibility to be more compassionate.
Yeah, I mean, that follow-up clinic is going to be amazing to see how these people do long-term. Alex, you were talking about monitoring people without directly contacting them. Were there special concerns about taking care of patients without going in the room that were unique other than TCDs? What was that like?
I think in general, I have anxiety about going into the room at all. I think as it's progressed and we've felt confident with our use of PPE, people in, but obviously we don't want people unnecessarily in the room for long periods of time. Kate did a great job of working with Cerebell, a company that uses limited EEG as a headband. So the nurse or the provider can just go in and throw that on quickly and leave, and you can remotely monitor EEG. It's a limited EEG montage, and the attachment doesn't stay great for more than 24 or 48 hours. But I think we've had to use innovation in order to monitor these patients more carefully.
That's really cool. And Cappy, you were talking about patients doubling up in the room. Was there any specific management strategy for taking care of two patients in the same room that was unique? Can you talk about that? Maybe you stepped away there. Anybody else who was taking care of two patients in the same room? I guess that was all of you at some point, huh?
Well, I think that's why I think Cappy showed the picture that we were like using dry erase markers to write on the.
Yeah.
And I think I use it a lot to kind of pinpoint which patient we were talking about and what their data was, and try to keep things a little bit more organized and really clear to the whole team about what was going on with each individual patient. The other thing that I found was I wish I'd lost 5 pounds before this pandemic started, because then it would be a little easier to get between the beds in the rooms to do procedures.
Yeah, just to, Chris, can you hear me?
Yeah, I can hear you now, yeah.
Yeah, sorry, I was muted on my phone here. So just to get back to what you asked Alex about, special considerations for going into the rooms. I mean, most of the high risk procedures that I think people were really concerned about had to do with airway management. and also CPR. So initially, when this whole thing broke, there was incredible, fear about, the idea if a patient codes, how are we going to do that? Are we going to go in and provide CPR? Are we going to aerosolize material into the environment and put everyone at risk? So I think, and also with airway management, I think rightfully so, the thought was, try not to bag these patients to the extent that you can. However, there was many instances, several that I can remember had to do with a patient self-extubating, right? So you can imagine if the patient's on isolation, everybody's in the hallway, all of a sudden the patient pulls their tube, and now it takes, at least 30, 45 seconds to get gowned up. The patient's hypoxic. You run into the room, and now your first priority is securing the airway again. So, on several occasions, having to bag the patients in those instances. I think it took some time, and even still now, I think there are different providers that are extremely, hesitant to advocate bagging. But I think, in an extreme situation, you just do what you have to do. With regard to the double bedding, we had at least some instances where, something as simple as the monitors being visible through the door, right? Where you have cardiac monitors on the other side of the room that are hard to see. The ventilator settings are difficult to see. So, those patients were certainly at a disadvantage. I don't think you could say that the ability to monitor those patients is anywhere near what it would be in a single bedded room. So these are all challenges that we had to sort of deal with on the fly. Hopefully we won't go back to a double-bedded, double occupancy again, but I think we all learned a lot from it.
If I may add to the, sorry, Alex, do you want to?
No, go ahead.
If I may add one other change to our practice. So before going into the room, if you were going to see the patient's neighbor, thinking about what the other patient in that room is also going to need, or also thinking about what your nurse or your respiratory therapist or somebody else who might have needed to go into the room after you would need, gathering all of your supplies as much as possible. If you're going to go into ultrasound one patient, you might as well ultrasound the other patient as well and gather data or check their plateau pressures. So trying to be as efficient as possible in terms of both data gathering as well as helping out other team members, so you could minimize the number of re-entries into the room.
But yeah, there certainly was triaging, even in an ICU, which we're not necessarily used to, working in an ICU in New York City. Oftentimes one patient had to be on a portable monitor, and that doesn't transmit to the nursing station. And so we would be switching which patient was on the portable monitor day to day, depending on which patient was sicker or, who went into AFib with RVR. And some of the ventilators maybe didn't supply the appropriate tidal volumes or the appropriate PEEPs. And so we were often trying to switch people's ventilators. So as people got better, they got the ventilators that, weren't able to provide as much PEEP. So there was a lot of triaging.
Do we have any data on how many healthcare workers got infected, or how many ICU workers, or, I haven't really seen any data on that other than data out of China.
So, I don't think there's great publicly available data out there. Like there's the publications from China that you're referring to, where out of 72,000 people, they have about 3,000 of them were healthcare workers. So that's like 3 or 4%, and Italy reported 20%. So there's definitely some reporting bias and selection bias through all this. What we do know is, if you follow the daily briefing from Cuomo, with all the testing, and it's reported that healthcare workers are less infected than the general public. I think somewhere in the order of 12% versus 19% in the general public. And a lot of that is attributed to PPE. But I don't think there is great data out there. Everything out there is what's on social media, and we have people compiling lists and keeping a memorial list, so to speak, right? I think there's this post going around on one of the social media platforms of close to 300 names of healthcare workers that have passed away. And this ranges from physicians, residents, fellows, attendings to nurses, EMTs, hospital maintenance workers. So, I'm sure the actual number is higher out there. These are just things that were compiled from various social media sources.
Yeah. While you guys were in the COVID ICUs, some other people had to step up into your old roles. And so we invited Ted Panoff to join the panel and comment on what it was like acting as an ICU attending.
Well, thank you, Chris. The two main points I want to bring up really are related to experience and humility. So the ability of the neurosurgery attendings to really bring their education to the table, and specifically the ability to deal with bad news. And that's something that my senior attendings have always stressed. Our ability to carry on those conversations became so important during the COVID crisis. And I think it helped a lot of the families, especially because that communication had to be over the phone, had to be over Zoom. So being facile with such conversations made it easier, for sure. And also our ability to share that experience with other people who have never had conversations like that before. We ran into nurses who were incredibly experienced, but said, this is the first time I'm seeing 2 deaths on my unit in one day. And the second one, again, is humility. I don't know if a lot of neurosurgeons will agree, but a lot of people outside of neurosurgery will probably say neurosurgeons can use some humility. Our ability to go to the floors as a team and to act as residents year 1, and to be able to admit that we don't remember how to write a full Chem 7 or how to write a full blood gas. Used inappropriately, that is dangerous and increases the possibility the team will dysfunction, but to use appropriately, it really improves the work of the entire team. It makes each team member realize how valuable they really are. And I think that we saw those moments, and we saw people really shine in the NSICU over at East, and the same thing in the NSICU over at West.
That's awesome. Yeah. I mean, thank you to the ICU team for giving us all those materials at the beginning to kind of learn online how to do all the things that you guys do daily, and then basically act as a consult for us to call you at all times, even though you're in the other ICU or sleeping. Let's talk for a minute or two about some of the manifestations of the disease. And a lot of people are very interested in the coagulopathy that happens with the disease. So I was wondering if, Cap, you could elaborate on the coagulopathy a little bit, and if there's any way to identify who's going to develop that, or any way to diagnose it. You're saying that there are not really any changes in the typical coagulopathy labs.
Yeah, so what we're seeing certainly in terms of the laboratory changes are, as I mentioned before, an inflammatory profile as well as an elevated D-dimer. And the D-dimer, we think, is a reflection of sort of microthrombi formation. And it was postulated that this might be contributing to the multi-organ failure. There was actually recently in the New England Journal, there was an autopsy series of 7 patients who died looking at their lung histopathology, showing, a several-fold increase. I think it might have been 10-fold increase in microthrombi in lung capillaries compared to patients who died from influenza. So this disease is different than other viral, syndromes that we know about. I think while we were not seeing, at least on our side, patients presenting initially with, large vessel strokes one after the other, we certainly, or pulmonary emboli initially, there's certainly on autopsy, it seems like there's many patients who develop pulmonary emboli. We have anecdotal, there seems like there's an anecdotal signal that there's an increased risk of stroke, and certainly a few STEMIs as well. So these things sort of all suggest that these patients are at risk for not just microthrombi and multi-organ failure there, but also these macrothrombotic events. What we've seen, it seems like the inflammatory profile is more pronounced in patients who are, it does seem to be correlated with severity of illness, but I think there's still a lot that we don't know about how this influences prognosis and how, whether or not anticoagulation is beneficial. I don't know if anybody else in the group wants to comment. I know there's been a lot of discussion on this subject.
I took care of patients who clinically looked like they were having PEs, again, too unstable to confirm with CTA, but these were patients that we were currently thrombolyzed. I've never given so much TPA before. We had patients who got up to 250 milligrams of TPA over 24 hours, and each time with a little bit of a response, and then they would worsen again. And these were patients we had on full heparin and giving TPA. So I do think there did clinically seem to be a lot of PE that we unfortunately couldn't confirm as we'd like to, but I've seen a couple of clots in transit on ultrasound. So I do think we have at least anecdotal evidence that there is hypercoagulability.
The confounder for that, obviously, with these patients, they're extremely hypoxemic, and so there's, a chance that there is very high pulmonary vascular resistance leading to acute right heart strain in RV failure, and that's been also reported in the literature. So oftentimes our surrogate for, suspecting a PE is a very large right ventricle or a failing right ventricle on our bedside ultrasound. But we don't really know, so TPA was used, as Dr. Reynolds said, fairly liberally on the off chance that these patients might have large clots. But there could be another reason for the RVs to be enlarged.
Do you think that people with mild COVID have coagulopathy as well? And I think I say that mostly because there's the report from our institution about the large vessel occlusions in young people with mild symptoms.
I can only speak from my own experiences that we were not, it didn't seem to me, although, I don't know that I have the ability to detect, still an important signal, but we weren't seeing, those patients with mild disease with, large either venous thromboembolism or a huge rash of strokes in those patients that you would consider mild.
Yeah, I saw the data from Viz.ai that the overall incidence of strokes, of stroke codes was down nationally by quite a bit, but that the LVO rate appeared to be stable. So maybe some people weren't coming in.
Right. I mean, that's something we've also discussed, that we wonder how much, other disease, what the impact of COVID has been even beyond the patients affected by COVID, right? That there's probably many patients who do not get the care for illnesses that they would normally have come to seek, care for just out of fear of the medical system.
And we've seen that at our own institution, both for heart attacks as well as large vessel occlusions. One of the patients was 30 years old in the 5-patient series from NEJM, also delayed coming to the hospital because she feared that she would get COVID-19. We've heard this story from our cardiology colleagues as well. It's published in the New York Times, experience from our institution. So another plea to everybody, whether you have COVID-19 or not, please seek the care you need. We're here, we're taking all due precautions. It's extremely important to call 911 if you have any acute weakness, facial droop, difficulty in vision, speech. I think it's very, very important. And really the onus is on us as a healthcare community to really engender confidence in our communities at large, that we are all our health systems are very, very capable of taking care of both COVID-19 and non-COVID-19 patients and provide the highest quality of care possible. It's not like when you give to one mission, the other mission takes away.
Thank you, Neha. I think that's a great comment to close on. Thank you to the NSICU team for amazing work and great presentations today. Have a great day, everybody.
Thanks. Thank you, Chris.